Good afternoon, everyone. My name is Ken Shaskus, and I am the program director here at the Foundation for Opioid Response Efforts. I'm excited to welcome you to our webinar today, focused on state policy landscape. Oops, sorry about that. Focused on the state policy landscape to address the opioid and overdose crisis in 2024. We previously held a webinar focused on federal policy, which you can watch a recording on our website at forefdn.org. But today we're going to be focused on state policy opportunities for the coming year to address the opioid crisis. First, some logistics for the webinar. If you've been here before, you know these. The webinar is going to be recorded and it'll be available on our website shortly after, and slides will also be available on our website for download. We will be having a Q&A session at the end of the webinar, but please use the Q&A button at the bottom of your Zoom screen to ask your questions. If you have a similar question, please upvote that so that we can get to as many of those burning questions as possible. There will also be a brief survey immediately following the webinar. We ask you to fill that out, as we are always looking for ways to improve our webinars. Now, for those who don't know us, we are a national grant-making foundation that was founded in 2018 with one mission, and as to address the opioid crisis. We always keep patients at the center of our work, and we focus on 4 areas of professional education, payer and provider strategies, policy initiatives, and public awareness. We have an incredible lineup of speakers today for you, including 2 FORE grantees who are performing research on state policies and providing TA and guidance to state policymakers and leaders. After they present, FORE President Dr. Karen Scott will moderate a fireside chat with 2 state leaders, Dr. Chinaza Cunningham, a commissioner of the New York State Office of Addiction Services and Supports, and Doug Huntinger, Executive Director for Drug Prevention, Treatment, and Enforcement, and Chairman of the Indiana Commission to Combat Substance Use Disorder. We'll then end the webinar with that Q&A sessions where we'll bring all of our speakers back on. With that, I'd like to introduce FORE grantee Katie Green of the National Academy for State Health Policy, or NASHP. NASHP has been using a FORE grant to help state policymakers as they navigate changes in substance use policy, such as flexibilities and expansions in service delivery and harm reduction, increases in federal grants and Medicaid options, as well as new funding resulting from legal settlements. So with that, Katie, take it away.
Wonderful. Thank you so much, Ken, and good afternoon. Thanks to the Foundation for Opioid Response Efforts for having me here today. My name is Katie Green. I'm the Director of Public Health at the National Academy for State Health Policy. We've been so thankful to work with the FORE team on our ongoing efforts to implement policies to expand access to OUD treatment, and I'm really happy to be here and share a little bit about some of the challenges and the opportunities that state leaders are thinking about for addressing the overdose crisis as we head into 2024. So for anybody that is not familiar with NASHP, we are a nonprofit, nonpartisan organization dedicated to advancing state health policy innovations and solutions. We like to say we are of, by, and for states. And we work with state health policy leaders across the executive and legislative branches to improve the health and well-being of people across every state. Next slide. NASHP's ongoing work is informed by an academy of cross-sector state officials from geographically and politically diverse states. But we also have ongoing work on specific projects across the domains of cost coverage and value of healthcare, behavioral population, public health, child and family health, aging and disability, where we convene cross-agency policymakers to develop policy ideas and share best practices. When it comes to today's topic, we know that addressing the opioid crisis is not the responsibility of just one agency. It's behavioral health, it's injury prevention, it's Medicaid, it's housing, it's social services. So bring these agencies together to talk about cross-agency approaches, alignment of efforts, and blending and braiding funding is really critical. Next slide. Reducing deaths and opioid-related harms is really one of the largest challenges that state leaders face, and supported by FORCE team, NASHP continues to work directly with state leaders to enhance access and outcomes for substance use and opioid use disorder. Some of the ways that we work with states include forums for state-to-state learning, including our state opioid settlement learning network, which brings together state policymakers from attorneys general's offices, public health, behavioral health, and opioid advisory committees to share strategies for improving alignment of state and federal funds intended to address the opioid crisis, and really think about strategies for effectively leveraging settlement funding to address gaps in the continuum of care. We develop state policy trackers and resources to help states advance evidence-based policies, and we also support states through direct technical assistance. Next slide. So before I dive into today's topic, I want to pause for a moment to talk about the state policy landscape in 2024. And despite all the oxygen that we know is going to be taken up by a presidential election year, there's still a lot to do and a lot of things going on. So first, just talking about where states are coming out of the pandemic. States made really massive investments in public health systems during the pandemic, but American Rescue Plan funding is beginning to expire in 2024 and 2025, and with states facing a funding cliff, the sustainability of some of these efforts are going to be a concern. Second, there's been a lot of movement in Medicaid. I know Brad will talk more about Medicaid unwind and its impact on treatment access, but overall, the complete picture of what this looks like and the impact it'll have is still emerging. I know some states have completed the unwinding process, and others are maybe halfway through, but they're continuing to use different strategies to engage individuals who may be eligible for enrollment. As of early March, we know that at least 17.7 individuals will be disenrolled, with an additional 39.4 million waiting to be reviewed. It'll take some time to understand the full impact and whether these individuals will migrate back to Medicaid, other forms of insurance, or remain uninsured. We've also seen a number of states confront large budget shortfalls in the Medicaid program for various reasons, which may complicate efforts to address SUD and behavioral health challenges within the Medicaid population. On the positive side, following North Carolina's example, we've seen some real energy on discussions around Medicaid expansions in states like Mississippi, Alabama, Georgia, which could really open up opportunities for expanding access to care. And we're also seeing states take advantage of new flexibilities in Medicaid to address social drivers of health and provide in-reach services in correctional institutions. And I'll talk more about that in a minute. But on the slide, again, informed by our academy, you'll see what state leaders have identified as some of their key priorities for the coming year. Efforts to address rising behavioral health needs, across the board workforce shortages, and the maternal and child health crisis have not only been at the forefront of state leaders' minds, but really intersect and sometimes complicate efforts to address the substance use and overdose crisis. Next slide. In addition to some of the broader context of the state policy landscape, there are also a couple of really important substance use trends that states are responding to. And a really critical challenge is going to be for state leaders to respond to a crisis that continues to evolve. As we all know, we've seen multiple waves of the opioid crisis, with the first two waves driven by prescription drugs and then heroin, respectively. And then beginning in 2011, we really saw a third wave where illicitly manufactured fentanyl drove really large increases in overdose deaths. Although we are still very much confronting the increased lethality of fentanyl and its impact on overdoses, we're now seeing what some are referring to as a fourth wave of the crisis, really characterized by overdoses involving stimulants and fentanyl, which accounted for 32% of U.S. overdoses in 2021. What this means, if we're going to effectively prevent overdoses and improve outcomes for people, is that we need to continue to adapt our tactics across the continuum of prevention, treatment, recovery, and harm reduction. Next slide. Another key trend is the rise in rates of overdose among youth and adolescents, which doubled between 2019 and 2021. This being despite the fact that youth substance use is really at historically low levels. Use of any drug is down 44% since 2004. Again, this is largely due to the role of fentanyl and proliferation of fake pills containing fentanyl that can make casual and experimental drug use more dangerous. In terms of how this needs to shape our approach, we know that substance use and overdose challenges are intimately linked to the ongoing mental health crisis among youth. And it really requires us to think holistically about prevention, including addressing the range and risk of protective factors in the long term, while also addressing some of those acute issues related to increasing overdose risk. Next slide. Another data trend that states are confronting is rising disparities in overdose rates by race and ethnicity, which continue to worsen, particularly for Black Americans and American Indian and Alaska Natives. Recent research has really underscored the role of social determinants of health in health inequalities and their impact on the overdose rates and opioid-related outcomes. And we know that addressing these disparities will require implementation of culturally responsive overdose prevention efforts and engagement with communities that have been disproportionately harmed. And I know there will be a lot of action at the state level to work with community-based partners. Next slide. So enough with the challenges. I'll turn to where there are real opportunities for states to make progress in 2024. The first is going back to Medicaid. States have always sought flexibilities within the Medicaid programs on the type of services and models for delivery, with Section 1115 waivers providing the most flexibility in terms of the ability to test new approaches and models of care. Beginning with North Carolina's Healthy Opportunities pilots, there's been an increased opportunity to think about delivering services beyond health and thinking more holistically about addressing ongoing health-related social needs like housing, nutrition, case management, and infrastructure. We know that access to social supports like employment services, transportation, and housing have really positive impacts on treatment and recovery outcomes, and a number of approved waivers, including those in Arizona and Oregon, are specifically targeted at meeting housing and other social needs for populations with SUD. Next slide. California, Washington, and Montana's 1115 waivers uh, around corrections are also an important piece of information. There's been really significant momentum around 1115 waivers that provide up to 90 days of in-reach services in correctional settings to support transitions to the community, which includes leveraging Medicaid to support MOUD treatment behind the walls, case management, and linkage to care as an individual is reentering the community. As I mentioned, California, Washington, and Montana recently had waivers approved that support MOUD in correctional settings, and then California's PATH initiative provides planning grants to support implementation of reentry services. So this could be really incredibly impactful given limited opportunities for treatment in correctional settings and what we know about the risk of overdose for individuals leaving incarceration. And I'll also say that a key challenge is for the success of these waivers and making a dent in the overdose crisis will be to ensure that an adequate treatment infrastructure exists within those community settings. So it'll be important to work across correctional agencies and behavioral health agencies to ensure that we don't lose people through these transitions. Next slide. Services for individuals with SUD are also an integral part of the larger momentum towards modernizing behavioral health systems on the state level. First, states continue to invest in a crisis continuum of care, including crisis call centers, mobile team responses, and stabilization facilities. These services provide individuals with substance use and behavioral health needs with linkage to care as part of a no wrong door approach to treatment. States are continuing to invest in certified community behavioral health clinics, which provide services to individuals with SUD in community settings. Housing for people with behavioral health needs continues to be a major priority for states. SDOH waivers are only one component of larger strategies at the state level to connect individuals with substance use disorders or serious mental illness to housing supports that are supported through a variety of funding streams across HUD, state opioid response funds, and other funding streams. And then lastly, SAMHSA has recently offered guidance on blending and braiding funding across different block grant programs, which really means strategically thinking about using different pots of money to support common goals or address multiple needs for a population. Blending and braiding can help optimize resources, promote sustainability, and help create integrated and more flexible systems of care. An important focus of our work over the past year has been in supporting state leaders in decision making related to opioid settlement funding. And I'll say that strategies to identify needs, address gaps, and better support alignment of funding, especially given the relative flexibility and long term nature of those funds, is critical to maximizing the impact of opioid settlements. Next slide. Just two more things I want to mention, and I know Brad will discuss some of the regulatory aspects in more depth. First, we've seen a relaxing of regulations around delivery of MOUD and naloxone, first through emergency authorities during the pandemic, and more recently, we've seen federal methadone rules that promote greater flexibility, the removal of the X waiver that eliminates training requirements to prescribe buprenorphine, and then the shift to over-the-counter naloxone. While these are all really positive movements that could pave the way for greater access, they're not in and of themselves a panacea, and I think there are both regulatory barriers at the state level that can be addressed, as well as implementation strategies that states can invest in to ensure that MOUD is better integrated into primary care settings, correctional settings, emergency departments, and communities in partnership with some of those individuals at highest risk of overdose. I think partnering with and supporting the capacity of harm reduction partners that are trusted by people that use drugs and continuing to build that community-based infrastructure to deliver services and provide supports will be really important moving forward. Next slide. To wrap up, again, I'll just say that the data is telling us that the crisis continues to evolve, and that as the drug supply has become increasingly dangerous, as we've seen more polysubstance use within overdoses, as we're seeing new challenges like xylazine, we need to be adapting our strategies. I don't think there's one single solution, but some priorities that can help support targeted efforts to reduce overdose are first, better data and surveillance. We've seen a lot of states utilizing opioid settlement funding to invest in infrastructure and analysis and sharing of data, allowing them to better respond to new trends, utilizing drug checking equipment, having a two-way dialogue with those organizations that are on the ground in community. All of this is really important as a feedback mechanism to better tailor those strategies. Better investment in the continuum of prevention strategies, from primary prevention to targeted and more culturally informed interventions for communities at highest risk. Another key priority is addressing legal barriers at the state level that prevent the implementation of evidence-based harm reduction strategies. And lastly, and relatedly, just harnessing the best tools that we have available to confront current threats, whether that is fentanyl test strips or drug checking equipment, making that available, or really paving the way for Medicaid to cover contingency management as an evidence-based treatment for stimulant disorder. And I believe that's my last slide, so we can go next. Yes, thank you. That's my contact information. Please do reach out to me if I can be helpful at all. I know I just scratched the surface of some of these topics, but a lot of work to be done, and I'm looking forward to the discussion. So at this point, I have the pleasure of introducing and turning it over to Bradley Stein, who is the Director of Opioid Policy Tools and Information at the RAND Corporation.
Katie, thank you so much. I'm really pleased to be here. You know, I think I'm going to pick up on a lot of the themes you touched on. I also very much want to thank FORE for the opportunity to share some of the work we've been doing with all of you today. and even more so to share them for their support to allow us to do a lot of the work that I'm going to be sharing today. Next slide, please. So during today's talk, I want to sort of touch on a couple different things. A lot of this does stem from the work that has been FORE supported that we've been doing. And I think at the basis of a lot of the work I'm going to be sharing and a lot more of the work we're going to be doing is really thinking about how do we use empirical data and analyses to inform state policy making and state responses and initiatives in a crisis that is evolving in a state policy environment that's evolving. So I'm going to sort of touch on a couple high-level things, dig down on a couple places, but then also sort of give a smattering of opportunities that I see going forward. I'm going to start with, I think, some of the things that we've learned out of COVID, because I do think that provided an opportunity to really examine some fairly dramatic changes that we had, and then sort of to bring it forward to what we see as sort of some of the shifts going on currently. Next slide, please. So, I think the COVID pandemic really triggered a whole variety of policy changes that really influence how we address not only the opioid crisis, but healthcare more generally. And so a couple of the ones that certainly get talked about a lot are dramatic changes in telehealth policies. Payment parity, so that if you were providing telehealth services, either audiovisual or some cases audio, you receive the same level of payment that you did for in-person services. With respect to treatment for opioid use disorder and medication treatment for opioid use disorder, an opportunity to initiate buprenorphine telehealth rather than in person. But beyond telehealth, I think there are a whole variety of other policies that sometimes we pay less attention to, but that also may have been important. Examples include authorizing treatment by out-of-state clinicians, which increased the pool of availability of clinicians who could provide telehealth. A variety of policy changes related specifically to the treatment of substance use disorders more broadly. These included bans on prior authorization, waiving of co-payments for individuals who were in treatment, less requirements, and less urine drug testing and other drug screening going on. And then liberalization of a number of policies, certainly with respect to Medicaid eligibility and individuals being able to stay on Medicaid. And Katie talked a little bit about Medicaid unwinding. I'll talk a little bit more about that later. But also methadone policies with respect to more liberal access to being able to take home methadone. Something so that for many people who weren't able to go to clinic every day, which is historically what had happened, the ability to make sure that they were able to maintain their methadone treatment for opioid use disorder. Next slide, please. So, as we look back at a high level, it certainly seems that a number of these things were positive when we look at sort of a high level picture of what we saw in treatment for opioid use disorder. Compared to many other types of outpatient care within healthcare, when we look at the data, medication treatment for opioid use disorder, both with buprenorphine and also to a large extent with methadone, stayed relatively stable in the first year of COVID, sort of in the year after the public health emergency was declared, which is when we saw the greatest changes within physical healthcare. Studies suggest that telehealth facilitated access for people receiving treatment who weren't going to clinic or who may live far from a provider and being able to get treatment. And studies also suggest that patient providers liked many aspects of telehealth, right? Certainly the ease of access for both patients, but also in some ways for providers and being able to see more patients from a larger geographic area. Similarly, less burdensome access to methadone because of relaxed take-home policies. I think a lot of people had concerns about diversion and potential increases in overdose. And I think as we look at the data there, we did not see those. So that certainly is encouraging, and I think contributed to a number of the changes that Katie alluded to at the end in terms of changing methadone policies fairly recently. However, next slide, please. But, I think as you dig into this, the policy stories become a little bit more nuanced and I think require a little bit more attention. So while there was liberalization of methadone take-home policies, at least a lot of the data I've seen suggests that many opioid treatment programs, methadone clinics, did not make use of these liberalized policies and still required the majority of individuals to attend daily to receive their methadone. Similarly, while there's a lot of attention to what may have the benefits of telehealth, as data started to come out, it really looked like, as you looked across multiple different types of insured populations, Medicaid enrollees, commercially insured populations, Medicare, that of the individuals receiving buprenorphine in all of these systems, it remained a minority of patients who were receiving buprenorphine supported by telehealth. Again, there the majority continued to be in person. And as far as initiating buprenorphine treatment, the one study that I've seen that involves commercially insured individuals in Medicare Advantage found that only about 10% of new buprenorphine episodes were initiated via telehealth. So one of the things that this had us wondering, and sort of we worked with FORE on and got their support for, was could we dig into this and sort of look a little bit more under the hood to try to understand a little bit more about what these policy changes were actually doing or potentially not doing on the ground, so that as we're learning from them, we can have more information going forward to inform the changes in policies that we have going forward. Next slide, please. So what we did, and we focused on buprenorphine here, is we used national pharmacy data dispensed from over 90% of retail pharmacies to examine buprenorphine. But moving beyond just looking at the total number of episodes, we wanted to sort of examine some additional things. So we wanted to see if we could detect sort of different patterns that may help us understand a little bit more about what we're seeing at a high level, and if these patterns shed any light. So we looked at sort of the number of people starting new episodes, the number of episodes ending, and we also started to look at the duration of episodes that were started sort of immediately before the public health emergency, both to see what the landscape of these were, but also to see if there was any association with these things as we looked at a variety of different state policies that might influence this, generally focusing on things that were sort of related to telehealth, but not specifically. This included initiating buprenorphine via telehealth, some of the payment parity I mentioned before, as well as other things that might have an influence, such as policies banning Medicaid prior authorization for substance use treatment, and policies allowing physicians or psychologists to practice across state lines, therefore sort of making telehealth more accessible for individuals, or at least increasing the number of potential providers for individuals in those states. Next slide, please. So what did we learn? That, overall, I think our finding was consistent with what other people found, that the overall number of buprenorphine episodes did remain relatively stable. But again, as you start to look under the hood here, I think there were some important differences. The one thing that really did jump out to us is we saw in kind of the period in 2020 after the pandemic, compared to the comparable period in 2019, we saw a substantial increase in the number of buprenorphine episodes that were paid for by Medicaid, and a corresponding decrease in the number of episodes that were sort of cash pay, that individuals were paying out of pocket. But as we started again to peel back the onion here and look at different layers, while the number of episodes stayed the same, we were surprised to see that there was a pretty substantial drop in 2020 compared to 2019 and the number of new buprenorphine episodes. And we also saw, not surprisingly, since the numbers overall stayed the same, a comparable decrease in episodes ending. So while the overall level stayed the same, there did seem to be this shift in patterns of care that we saw. And so one of the things that we then looked at is, okay, to what extent may some of these shifts be associated with states that were implementing one or more telehealth policies or some of the other policies we looked at? And at least at the population level, we were a little bit surprised in that despite this idea of telehealth offering greater access, the telehealth really, none of the telehealth policies that we looked at really seemed to be having that much of an impact by themselves on what we were seeing in sort of buprenorphine treatment episodes. When we did look at states that implemented like the entire package, a whole bunch of the telehealth policies, we did see some shifting in sort of the number of episodes beginning and ending, but it was really relatively modest. In fact, as we started to sort of tease this out, and if we were able to find any signal, the strongest signal we've been able to find so far is that states that were allowing psychologists to practice across state lines had sort of the greatest impact in being associated with longer buprenorphine treatment episodes for those individuals who were starting treatment immediately prior to the pandemic. So, I think this gives us pause as we're thinking about, and there continues to be a lot of conversation about telehealth. And I'm a firm believer in telehealth. I'm a practicing clinician, and I provided telehealth throughout the pandemic, and I still continue to for some of my patients. But at the public health level, I think this sort of makes us take pause and want to understand this a little bit more, or at least speculate about what may be going on. Next slide, please. So as we're sort of exploring this ourselves and talking to colleagues and sharing some of these findings about why telehealth didn't seem to affect things at a population level, I think a couple things come to mind. One I touched on before is that while there really are studies suggesting that telehealth may be beneficial to patients receiving telehealth and may be beneficial to those patients receiving buprenorphine via telehealth, that relatively few patients, or a minority, are receiving buprenorphine treatment via telehealth. And as a result, in terms of moving the larger public health needle, in terms of overall treatment, it may not be having as great an impact. The other thing I think we need to be particularly attentive to is that telehealth may be shifting which individuals receive care or the nature of care provided, but again, not changing care at the population level. This may be particularly problematic because we know from other studies that there are a whole variety of populations historically disadvantaged that may not have sort of the type of technological knowledge to take advantage of it, may live in communities where you don't have the broadband access to take care of it. So while telehealth may be beneficial to some, it may actually be exacerbating some of the disparities for our more vulnerable and disadvantaged populations. And I think as we're considering the equity of policies, not just the impact, that's something that's really important to consider. I think the other thing that we need to consider that all sort of know in the back of our mind is we're having a meeting via Zoom, is that COVID caused a whole variety of contemporaneous changes in policies and societies and the way we interact. And so while we may be focusing specifically, paying a lot of attention to the policies that come to mind and are most obvious, like telehealth, there may be others behind the scene that may be equally important. And so I think as we're continuing to try to understand and inform policymaking, I think these are things that we need to be thinking about and considering, hopefully getting more data about. But for those of you who are policymakers online, at least understanding some of these shifts in nuance so that you can anticipate some of these issues as we're considering new policy initiatives. Next slide, please. So that's several years ago. We're talking about policy changes that came in place in 2020. But as Katie referred to, there are all kinds of policy changes that are still taking place. And one of the most profound is Medicaid unwinding. So as I'm sure almost everyone on here knows, Medicaid is the country's largest payer for substance use disorder treatment. An expansion under the Affordable Care Act increased the number of individuals with substance use disorder treatment receiving treatment, and particularly buprenorphine paid for by Medicaid. During COVID, states were required to maintain Medicaid enrollment. We're not able to disenroll people in the way that they had before then. But continuous enrollment requirement has now ended. And so you're seeing disenrollment, which we refer to as Medicaid unwinding, with wide varieties in terms of states in the way they're approaching this and the number of individuals being disenrolled. Certainly, as we hear stories, we hear lots of people talking about the deleterious impact of Medicaid unwinding on those receiving treatment for opioid use disorder and substance use disorder, where they're not able to get treatment, or their providers are sort of removing them, or they have to change providers. And we all know how disruptive change in providers can be in successful treatment. Next slide. So again, here, I think the story may be more nuanced, and I think there are things that we need to be paying attention to here. The COVID policies were clearly important for many, and it allowed many to continue to stay in SUD treatment. But one of the things that we've certainly thought about as we've looked at the patterns in people staying in treatment for longer is, to what extent did this shift in Medicaid allow people to stay in treatment for longer? And might that have had an impact on sort of reducing the number of available slots for new people able to get treatment? So I think those unintended consequences are something that we need to be paying attention to. Was there potentially an unintentional barrier due to a lack of provider and clinician slots? Now, I think it's hard to imagine that unwinding isn't going to be harmful for some people. But as I think about policies, and you've heard me sort of allude to this, I think it's critically important that we just not think about, does a policy work or not, but for whom, right? And there are different populations that may be more or less affected by changes in policies. And I think that's going to be critically important to be able to better understand as we think about Medicaid unwinding. And so we're very grateful to the FORE Foundation, who's recently funded a project that's going to allow us to examine some of these issues, not only examining the overall impact of Medicaid unwinding on treatment, buprenorphine treatment for opioid use disorder, but really sort of diving again under the hood and seeing, can we detect, are there changes in the patterns of treatment that are going on? Are there changes in the types of populations being served, or the way providers and clinicians change their behavior? So I think this is one of the areas that we continue to pay attention to, because as I mentioned before, the policy environment as and continues to change. And as it changes, I think it's critical for all of us on the research side to do the best we can to produce useful, credible, rigorous evaluations to inform policymakers. Policymakers can't wait for that. The policies need to come into place before research takes time, no matter how quickly we try to do it. But at the same time, policymaking isn't a one-off. And as these things continue to evolve, I think it's important to continue to try to produce that information for more informed policymaking. Next slide. So to end, I just want to touch on, I think, Medicaid unwinding that has certainly come up and is creating a big change. But I think there are a number of other larger changes that either have occurred at the federal level or occurring in the drug use environment around us, that are things that also we need to be paying attention to. And I know some of my colleagues are starting to look at to try to understand the potential impact of these policy changes. Katie mentioned that recently SAMHSA just issued regulatory changes that are going to greatly facilitate access to methadone. And I think a lot of this comes out of what we learned during COVID, that by increasing access really didn't lead to an increase in methadone-related overdoses. But again, here, I think we may see variable uptake of the new policy, such as we saw during COVID. Just because you've removed that barrier and created flexibilities does not mean people are going to be taking advantage of it. Here too, I think there's questions about equity. Who's going to benefit from this? And also, what are the possible unintended consequences? And this is something I'm really attentive to in the area of sort of substance use disorder more generally, because oftentimes well-meaning beneficial policies may have concerning unintended consequences. One that certainly I've heard talked about here is, to what extent is this potentially an issue for the business models of opioid treatment programs? And these are facilities that are not terribly wealthy. They run on very, very thin margins. And recently, actually, within substance use, we've seen an influx of private equity, which has sort of changed the market. This is a fairly dramatic change that might impact how those businesses run. And I think for state policymakers to be alert to that in your own state, because there may be unintended consequences as we look forward to what the methadone provision environment looks like 5 years or 10 years from now. Katie also mentioned that as of last year, there's no more X waiver for buprenorphine. So just briefly, prior to that, you had to take a brief 8-hour training to be able to prescribe buprenorphine for OUD, that requirement was abolished. But again, here I think there's questions to what effect is that going to have. At least some of the preliminary data I've seen suggests that at least so far, we're not seeing dramatic changes in terms of buprenorphine prescribing. And I think this is consistent with prior studies that have suggested that removing barriers to buprenorphine prescribing really didn't cause as many changes as we thought we've had before, or that were expected from that. And so I think here too, it may be time for us to sort of take a step back and think about why that might be. I think one of the things that's come out of our studies is removing those barriers hopefully gets more people into prescribing. But prior research that we've done has shown that 70% of clinicians who start prescribing buprenorphine stop prescribing within a year and no longer prescribe. And so if you're getting people in, but they quickly stop prescribing, the impact of that in terms of provision of greater amounts of buprenorphine may not be as much as hoped. And maybe it's time that we start to consider other sort of mechanisms, potentially more proactive mechanisms about not just getting people to start prescribing, but rather how do we encourage that 10% who start and go on to increase the number of prescribing where they're sustainably treating more than just a handful of patients? How do we move and support more clinicians into that group? Xylazine, another issue that Katie mentioned, which is increasingly showing up in injection drug use and is causing terrible necrotic wounds. This is not something that, at least so far, we're seeing a demand pull for. This seems to be something that's sort of penetrating the drug supply, but it's not something that people are seeking out, which means there might be a really important opportunity here for test strips and other things to alert drug users to when their drugs might be contaminated with phentazine, with xylazine, so they can avoid it. Again, I think we're seeing a number of states start to move in this direction. I think the federal government is starting to move in this direction. Here's another opportunity that I think we need to consider. Next slide, please. I think the other thing I want to draw attention to, and again, Katie touched on it, is a lot of my conversation and a lot of really where we've emphasized a lot of policy activities has been around medication treatment for opioid use disorder. In some ways, it really is the gold standard. It has better evidence for helping and preventing fatal overdoses than non-pharmacologic interventions we have. But I think it's critically important to also point out that we don't have medication interventions for other substance use disorders. At this point, there's nothing out there. So we need to think about not only medications, but how do we support effective use and effective uptake, adoption, and use of other types of non-pharmacologic treatment for substance use disorders. And I think one that I'm hearing talked about increasingly is contingency management, which has probably among the most robust evidence bases for the treatment of stimulant use disorders, which is becoming an increasing problem. So there's pretty good evidence that exists, but historically, because of some federal rules related to kickback in the Office of the Inspector General, there's been great reluctance and very little uptake of contingency management. But I think we're starting to see some relaxation there. Contingency management is increasingly used in the Veterans Affairs healthcare system for the treatment of substance stimulant use disorders. Katie mentioned that a number of states have received CMS waivers to increase use of contingency management within Medicaid populations. And recently, in a way I think that may actually potentially have the broadest impact, is several months ago, the Office of Inspector General has announced its intention to create a safe harbor provision for contingency management. The details of that are not yet determined, but by sort of creating opportunities to allow clinicians and systems to use this more effective treatment, I think opens up a much wider range of opportunities to states to think about how do we support when this door opens, or how are we prepared to support our systems so that our constituents receive this effective treatment. Next slide. So, I think one of the points I want to leave you with, and this is a different version of the slide that Katie showed previously, is over time, the opioid crisis has evolved and the policy environment has evolved. And as a result, our responses to it must evolve. We need to be considering different policies now than we were considering a decade ago, when the overdose crisis was being driven primarily by opioid analgesics with the growth of heroin. And so I think this is sort of an ongoing battle and one that we need to continue to fight. Next slide, please. So, I tend to think of it as a wheel. We need to implement policies, and we need to implement policies using the best available information. Usually, and hopefully out of these policies, there are going to be some gains, but not always, and not necessarily for everyone. And so I think it's important for policymakers to be able to work with others in your realms, others in your states or nationally, to really start to understand what are the impacts of these policies and for whom, and what may be some of the unintended consequences, so that as the next round of policy making occurs, we can continue to have informed policies. Really, the cycle is critical. And in the face of the cycle, I think it requires humility. Our research tools are limited. They take time. So I think we all need to be careful about anyone saying, here is the next silver bullet. Here is what we need to do. That level of certainty for any of these questions makes me very uncomfortable. It's a complicated, wicked crisis that involves not just drugs, not just the healthcare system, not just the illicit drug system, but all kinds of social determinants of health. And so I think as we try to understand and conduct informed policymaking, we must be duly humble about the complexities with which these challenges face us, and really try to learn from all of the stakeholders, not just providers, not just policymakers, not just individuals with lived experience, also their families and loved ones, who I think are a critical piece of the table that oftentimes we may not be listening to enough. All of these people need a place at the table. This problem is not going away. I wish it was. I wish this was an area of research that I was put out of business and I could turn to something else, but it's not, and it doesn't appear to be in the near future. That all of us working together can make critically important strides so that 5 years from now, we're implementing policies to address the evolving crisis, informed by what has and has not worked today. Thank you very much. Next slide. Here is my contact information. Happy to answer questions. We also have a NIH-funded center that spends a lot more time digging into these issues beyond what I've been able to share with you. There's a QR code, or you can always find it on the web. Thank you very much.
Brad, Ken, Katie, thank you so much for the terrific presentations and getting the first half of the webinar off to an incredible start. I also want to thank our audience. We've got terrific engagement, lots of great questions coming in. So please continue to put your questions in the Q&A box. Again, I'm Dr. Karen Scott. I serve as president of the Foundation for Opioid Response Efforts, and I am so thrilled to welcome Dr. Chinazo Cunningham, who's commissioner of the New York State Office of Addiction Services and Supports, or OASIS, and Mr. Douglas Hutzinger, who's chair of the Indiana Commission to Combat Substance Use Disorder. Both Dr. Cunningham and Mr. Hutzinger have agreed to engage in a fireside chat and a dialogue, and really pick up on some of the points that Brad and Katie highlighted in their short presentations. So welcome again, Chinazo and Doug. And I'm going to ask each of you to just take 3 or 4 minutes or so, and just give our audience a little bit more of an introduction about your work, the work and the agencies that you lead, and perhaps begin to flag some of the priority issues that you're focused on for this year. Chinazo, we'll start with you.
Great. Thank you so much, Dr. Scott, and thank you so much for having me here today. It's really an honor to be part of this discussion, and thank you to FORE for all of the work you do in this space. So I'm Chinazwa Cunningham. I'm a physician trained in internal medicine and addiction medicine, and spent my entire career really working in New York on addiction. I'm the commissioner of the New York State Office of Addiction Services and Supports in New York, and really, so every state is organized differently. We have our own office specifically for addiction services, period. We are not part of the Department of Health. We have a separate office that deals with mental health, and I report directly to the governor. So that is how we are organized in New York State. And so I really have the privilege of leading all aspects of addiction services across New York. You know, as everybody mentioned, we're in the worst overdose crisis ever in New York. We've had over 6,300 overdose deaths. That's one person dying every 90 minutes. So we certainly recognize the urgency here to really leverage the investments that we have and the changes in the regulatory landscape to really improve access to services. We at OASAS oversee 1,700 prevention, treatment, harm reduction, and recovery programs. We serve more than 730,000 individuals. We work very closely with community-based organizations who do really the bulk of the work on the ground. We have 12 state-run addiction treatment centers that are inpatient or residential programs. We certify all of the addiction services in New York State, and then we also oversee the credentialing for all of the professionals who are counselors addressing substance use as well as gambling. So I've been the commissioner for over 2 years, and really my guiding principles, given my history and experience, are really to make sure that we are embracing harm reduction, that we are using a data-driven, evidence-based approach, and that we are using an equity lens in everything that we do. We also really are focusing on a comprehensive approach to reduce stigma, which I see as the #1 barrier to really identifying and accessing services. So I'll stop there because I know there's a lot of other things we're going to touch on about really what we're focusing on. And it's really, for me, you know, it's a double-edged sword. It's obviously there's a ton of tragedy, but it's also a very exciting time where there's really new opportunity that we have to take advantage of as we move forward in the field of addiction.
Great, thank you so much, Dr. Cunningham. Doug, turn to you.
Thank you, Dr. Scott, and again, thank you to FORE for having this forum. So as a member of Governor Holcomb's cabinet, I'm responsible for the state's response to the drug epidemic. So in 2017, when he took office, he created the position that I hold and have held for the last 4 years. And we're really responsible for aligning, coordinating all of the various state agencies that have a hand in this response. So everything from our Department of Correction to our professional licensing agency to our Department of Health and our Division of Mental Health and Addiction, which we work really closely with, is that's where most of our money is located in Indiana. When it comes to, we also oversee the National Opioid Settlement Funds in Indiana. The state splits our funds 50-50 with state and locals. So we oversee that 50%. And we've worked really hard to embed that into our state agencies, just like we have with our SOR funds, ARPA dollars, and any other federal funding that we've received. We spend a lot of time with our intervention points, so our emergency departments, our justice system. I'm a member of our Justice Reinvestment Advisory Council, looking at how we can make improvements to the justice system, really expand the use of treatment courts, and really look at how can we ensure that we're setting people up for success as they exit that system. We're also, we've launched harm reduction street outreach teams. I don't have, prior to 2017, I didn't work in this space. And so being able to come in with an open mind being able to learn, I think has been really valuable in some ways, because I like to say my skill in state government is getting the bureaucracy to move a little faster, a little more efficiently, and really relying on the experts that we have here at the state. This is likely my fourth and my eighth and final year in this role. And so we're spending a lot of time making sure that we are cementing that program that is really rooted in evidence-based programs, that we're embedding that into kind of the fabric of the work that our agencies are doing, so that we're really setting that next administration up for success while continuing to support the programs that we've put in place over the last 8 years.
Right. Thank you so much for those introductions. I want to pick up on a couple of the themes in Katie and Brad's talks. And one of those is both noted some of the movement at the federal level can be to learn from what happened during COVID, some of the things we sort of tested during COVID in terms of some temporary flexibilities that we're now seeing reflected in some more permanent guidance, such as around the opioid treatment centers and around telehealth policies. But we also saw during COVID that what happened at the federal level in terms of guidance didn't necessarily translate down through states and to providers and ultimately to patients and participants, obviously equally across the country. So would love to hear from each of you how you see some of those next steps and opportunities, as well as the challenges from the state perspective of, seeing something come out from SAMHSA and, and where you go next with it. So again, maybe starting with Chinazo.
Yeah. So we're very excited about these changes, and we really plan to leverage them as much as possible. I mean, I think, as you mentioned, just because there's regulatory changes does not mean that we see changes in behaviors or practices on the ground. And so we've certainly seen this during COVID, for example, with the flexibility for dosing, really looked very closely at what was happening, working with programs to try and enhance that flexibility. And what we saw over time was this flexibility became more and more limited over, an 18-month period. And so while it's important to have that, we know that it's not enough. And even with changing our funding stream, for example, having a bundled, payment rate with our opioid treatment programs, that still was not enough, along with the regulatory changes to get the kind of changes that, we want the programs to leverage. So some of the things that we're doing, again, really excited about, include mobile medication units. So we are funding 11. So we have actually one of the biggest opioid treatment programs, system in the country. We have over 100 opioid treatment programs in New York State. And even with that, we know it's not enough, and especially with fentanyl and the really high, potency opioids, that we know that methadone is even more important now than ever before. And so a lot of our focus is really on expanding our opioid treatment programs and their access. And so mobile medication units is one key way. So we're funding 11 of them and investing more than $6 million in this. 2 of them thus far have been up and running, but there have been a lot of challenges to getting the units, to getting, the specifications from the DEA. With that, having to sort of jerry rig some of the things that, were not fabricated because this is not a common thing. And so learning, making sure that our programs are learning from each other so that we can, be more efficient as they continue to roll out. We've also invested over $20 million on low threshold buprenorphine initiatives. So really using telehealth. We have programs going out into parks, providing buprenorphine treatment in parks, going to where people are, really meeting them where they are and those who are at highest risk to get people, life-saving medication. We're also focusing on integrating our outpatient programs with our opioid treatment programs so that people can have more comprehensive services. And that's another way to expand opioid treatment programs. So if we already have an addiction outpatient program, it's much easier to just insert a medication unit in that rather than starting from scratch. And so that's another big investment where we're, more than 50 programs are doing this and investing, over $14 million. Another area that I'm very proud of in New York is the work in jails and prisons. So we are the second state in the country that requires every FDA-approved medication for the treatment of addiction to be offered in every jail and every prison. 44 prisons, 58 jails. That is a heavy lift. I mean, you spent a ton of time doing this, and all jails, all prisons are offering all forms of medication. So we're working really closely with our opioid treatment programs to do that. As you can imagine, it's very challenging for methadone, but these kinds of, but the telehealth and these flexibilities really, are important to make that happen. And then, as I mentioned, we're really working with programs around flexible dosing and how do we get them there, besides for just the regulatory changes, besides for the financing changes, what else is needed for systems to change. And so some coaching and learning about barriers. We have an NIH funded study. We're working with some academic partners to really understand that a little bit more, along with the mobile medication units, another NIH funded study to really understand that work. Who's accessing those? Is it the same people? Are we reaching new people? What are their outcomes going to be like? Are they going to be similar or different? So really, so those are a lot of the areas that we're focusing on. And again, I am thrilled to be in this position to do this work. And I really think it's changing the landscape and improving access to methadone and other medication.
Right, thanks, John. It sounds like it's offering a lot of opportunities, a lot of different strategies and opportunities for people, for providers, others to pick up on, to find the piece that they can start with your support. Really helpful to broaden that discussion. Doug, let me turn to you sort of again around the translating from federal to state. How does that look for you?
Yeah, so we too are really excited. We've spent the last 7 years working to double the number of our opioid treatment programs. One, to ensure that every Hoosier, regardless of where you live, is within 1 hour's drive of an opioid treatment program, but also to drive down the average drive time to now where we're at about 16 minutes. So, and that's for our current program participants. So the access has been critical in Indiana. When we started in 2016, opioid treatment programs were just the beginning of our challenges in ensuring that that full continuum of care was available. We have some additional challenges. During the time where methadone clinics were often sort of, it was the Wild West of their time. The state legislature put some pretty restrictive legislation in place. Our rules are also mimic a lot of the federal standards and guidelines, and so to make rule changes, it takes about 9 months here in Indiana. We currently have some rules going through for medication and mobile units, which will really help us as we work for implementation of all 3 medications into jails and prisons. I admire those who have done it. Looking at the future, we have a lot of hurdles to overcome. We have 91 jails in Indiana, and while we have about 1/3 of our jails offering some form, we only have 1, sometimes 2, depending on the day, that have all 3 forms available. So we've got a lot of work to do, and it's going to require us to really have some hard policy discussions here in Indiana about how we want to see the future of our OTPs regulated.
Great, thank you both. I was struck too by Shanaz, your comment that even with the payment alone isn't enough to sort of move the needle and make that translation. It sounds like, to your point, Doug, a lot of the sort of almost more cultural and environmental aspects of changing systems really have to be a part of how we think about this as well to get to those improvements. I wanted to, one of the other things that Katie and Brad talked about, and we always sort of come back to that, how many waves, unfortunately, of this crisis, of the overdose crisis, but thinking about the evolving crisis, which we as a fairly new foundation set up to focus on this, are always very, very mindful in talking about. But we also are very much in an evolving policy environment broadly. And certainly just in the last few weeks have seen a number of events or actions that kind of that are reverting back to a more legal or criminal justice approach versus the public health approach that I think we all have been working to advance in the past few years. So would love to just hear your thoughts on how do you think about, how you are thinking about that, and kind of recognizing that wanting to advance evidence-based work, but also recognizing the reality of sort of where we may be in many parts of the country in terms of the overall policy environment. Maybe I'll start, Doug, if I can start with you this time. Your thoughts.
Yeah, so I think we've been somewhat lucky in that we're new to maybe a little bit of this public health approach to things. Syringe service programs aren't something that we have previously had prior to 2015. So we're not on sort of the front edge of the backlash. We also haven't legalized marijuana in Indiana, and so some of the pushback that's coming from these decriminalization efforts and a desire to shift toward some more criminalization and harsher penalties, we're somewhat insulated from that right now. We've been able to grow our harm reduction street outreach teams, where we have teams that follow up on overdoses. They're knocking on doors, making sure that individuals have harm reduction supplies, that they're aware of what supports are out there. We've been able to grow our recovery hub system, and these are 22 hubs across the state that offer referrals and when I say referrals, offer that warm handoff to treatment, but also when individuals come back, they provide that psychosocial support, job training, housing supports, really looking at those social determinants of health impacts. And then through our work with JRAC, the Justice Reinvestment Advisory Council, we've spent a lot of time with our criminal justice stakeholders, trying to, our Sheriff's Association, getting them to understand the importance. And in many of them, especially, as we've funded treatment in jails, they've seen a shift in how the behavior of their jail population. As we've worked to streamline how cases move through the system, to create more recovery courts, we're seeing individuals move through the system faster. We're seeing them recidivate much less, which is leading to fewer overcrowded jails. And those actions are creating that positive reinforcement that is really leading this idea that we can treat our way out of this epidemic here in Indiana.
Right, really helpful. Thank you. Really helpful. Chinaza?
Yeah, so I think, it's just really important to acknowledge that the war on drugs was a failure, and a policy that was very racist. And, I think we have to say those words out loud, and we have to make sure that we don't make the same mistakes going forward. And, that's why harm reduction for us is really one of our key guiding principles, and our, equity approach as well. So, we're really committed to a public health approach. We really are focusing on expanding, prevention and harm reduction and treatment and recovery. We do recognize that many people with addiction touch the criminal justice system, and we want to prevent that as much as possible. And then certainly we want to partner when that happens, right? Because we want to make sure that when people are involved in the criminal justice system, that they have access to high quality evidence-based services and treatment. And so, that is, so we have a criminal justice division at our office who really spearheads all of the work with our jails and our prisons, also with our courts. partnering with law enforcement, making sure they have naloxone, making sure that they're trained, right? So we definitely partner with our other state agencies who are, law enforcement and involved in the criminal justice. And we just, want to make sure that those individuals who touch those systems will have access to the best services that they have and really partner together there.
Mm-hmm. Mm-hmm. So let me just follow up a little bit more on that though. So Chinazo, are there sort of is there messaging or data evidence stories that you're finding are helpful, say when you're talking about harm reduction approaches with some of the other agencies that may be more focused on the criminal justice side?
Yeah, I mean, I think that people are really now people feel more open to having these discussions than ever before, right? I mean, harm reduction is not new. I mean, I as a physician, I've been doing this work for decades, but I think for some people it is new. I mean, for some people in our own treatment system, it's new, frankly.
Mm-hmm.
I mean, some have been practicing harm reduction for decades, so I think there's really a lot of variability with law enforcement in the criminal justice system and in our own system. But, I've gone to jails personally and talked to sheriffs, and I've had sheriffs say it's all about harm reduction. And I nearly fell off my seat hearing that. But it's because, I think as Doug mentioned, they've seen the change in the population. They've seen, right, there's less challenges. People are less irritable. There's less diarrhea. There's less, right, it's easier for the correctional officers to take care of people who are not in opioid withdrawal. And so I think that part of what we're trying to do is also take those individuals who have really made that change and have them really be, the leaders in the field and talking to their peers, because sheriffs listen to sheriffs, right? Police listen to police. And so really partnering with them to do that. So it has been really positive, I think, the change that we've seen, and sometimes shocking to me, frankly. But I think it's been a really positive change. And so people, law enforcement they went into law enforcement. They did not go into this to become social workers, right? And so they want the help. They want the handoff. They want us to partner with them. And so I think, it is a space where there's just a lot more willingness and openness to working together. And I think that's really positive.
Right, really helpful. I think that's really a great addition to the conversation. We're gonna bring back on Katie and Brad as well and turn to some audience questions in just a moment. I'm gonna ask each of you though, Doug and Chinazo, before we do that, is just one really quick final optimistic, positive thing that you're excited about focusing on this year. Doug?
Yeah, so here in Indiana, in 2022 and 2023, we've seen a reduction in overdose deaths, roughly 5%. And so for me, that gives me hope. It also arms me with data for those detractors and saying that the work that we're doing is working.
Yeah.
And so I'm really excited. We distribute over 24,000 doses of naloxone every month here in Indiana, and while that's keeping that is keeping people alive until they hit an intervention point, and we're able to then embrace them in the system that we've built. And so we've got a lot of work to do. And I think what I'm really excited is knowing that as we're having success, that is going to help us continue this work long after our administration.
That's great.
So I'm really excited about harm reduction and really embracing that at the state level and at our agency level. I'm also really excited about the expansion of methadone with our opioid treatment programs and all the new ways to do that. I think the other point I want to make too that we didn't get a chance to touch on is really supporting the workforce.
Yes.
This is something that is critical. I don't go to a single meeting where I don't hear about workforce issues. We're frankly decades behind in terms of we haven't invested in the addiction workforce. So, we have so much catching up to do. There's no single answer, but we are really doing everything that we possibly can do to retain the existing workforce and then to really build the pipeline to bring people into this field. And so we have many, many initiatives, scholarships, bonuses, fellowships, paid internships, loan repayment, you name it, we have it. But we have so much catching up to do.
Yep, thank you. Thank you for making sure we got that in as well. Yes, thank you. Let me turn to, we've got a great set of questions, so I'm going to try to pull in some of those. There were a couple of questions early on about data sources, and particularly what data is available publicly at the state level. And so, Brad, maybe I'll start with you, but you each may have something to.
Sure. So I think there are a whole variety of data sources available. Ones that we tend to use, certainly the CDC has done a nice job in terms of tracking fatal overdose deaths. Now, one of the things that I think some states have put some money into that I think is a missing piece of that is non-fatal overdose deaths, which I think is critically important. I think one of the reasons so much of our conversation is about fatal overdose deaths is because we have the data there. There's certainly decent data from SAMHSA around treatment facilities. And that sort of, and you're able to see how some of those are evolving over time. So those are certainly some, but I think oftentimes in looking at community levels, one of the things I found most heartening is seeing communities investing in sort of tracking what's going on in their own community. And I do think that that's critically important and one of the things that we haven't paid as much attention to. The other thing I do want to draw attention to, because I think it's important, is we really actually have very little idea of what's going on in terms of illicit drugs and illicit drug markets. And so one of the things in terms of fighting the evolving changes in substances that individuals are taking is we're really doing that blind. Historically, there are a number of federal initiatives such as ATOM to gather some information. And I know some communities are now investing in sort of wastewater and monitoring there, sort of capitalizing on what we've learned from COVID. So those are other areas. I just covered an entire range of things, but I do think making sure that local data that's actionable and recent is critically important. And I think there's some models to point to in ways to do that.
Great, thanks, Brad. Let me turn to our Chinazo. Sounds like.
Yeah, data-driven approach is one of our guiding principles, and I'm a researcher, so I'm all about this. And I'm very proud of the work that we're doing. We have dashboards that are now available to the public so that people can look at the overdose crisis by their county, by their population, really sort of slice and dice the data. They can look at the entire treatment system. So all, people, every part of the system. So who's coming in what county, what population, can really slice and dice that. So that can really guide their work at the county level or the regional level. We have an opioid settlement fund tracker. You can see where every single dollar has gone, in what area, how much money the counties have gotten, what programs got funded, what initiatives got funded. So all this, you can see how much naloxone is going out, fentanyl test strips, xylazine test strips by county, by population. So we have several dashboards that are really available to communities to really see what we're doing and to help guide their work. In addition to coming out with, timely issues, like we have an addiction data bulletin. So one of the things that somebody mentioned was about stimulant use. So like, what does stimulant use look like across New York State? Who is it affecting? What counties are most affected? What does that look like for the treatment system, right? So we just just made that available publicly. So data are critical, absolutely, and it needs to be transparent. And so we're really working hard to make it transparent and available to the public.
Thank you. Doug, anything else on?
Yeah, no, so we were really lucky to benefit from a previous administration's investment in our management performance hub, which the goal was to be able to aggregate data across different agencies across the state. So aside from kind of a lot of the data that was mentioned earlier, one of our initial projects was EMS, naloxone administration heat map, so that people could see that naloxone was being administered in their own communities. Unfortunately, as you start distributing more naloxone, people stop calling EMS. And just like the emerging, as our responses changed to this epidemic, so has our reliance on different data sets. Most recently, we had one of our researchers look at emergency department data, jail and DOC release data, and EMS runs and naloxone administration, was able to aggregate that. And what we found was that that individuals who were in an emergency department that were deceased, 70% of those individuals died within 90 days. And so that allowed us to then break that information out by hospital, go to each hospital and our hospital association to really talk about what sort of interventions, how we can implement peers, how the state can help fund some of these supports. And what we saw is if you look at the data, you can see when the hospital began implementing peer recovery coaches in their emergency department, and you begin to see the time begin to grow, and the percent of individuals expiring begins to decrease as well. So data has been incredibly helpful in our fight.
Right, that's what we would hope to see, and work around the emergency departments, and then connecting people with treatment is another area that we've also been supporting work around the country. So it's always good to hear, but building up that evidence for it is important. Katie, should I get you?
Yeah, at this point, everybody has mentioned pretty much everything I was going to say, but kind of just to jump on Doug's point a little, I think some of the most powerful data that we have out there is not specific to drugs. It's housing, it's corrections, it's understanding those social vulnerabilities and where additional resources are needed. And I know this is something that Indiana is really good at, is understanding where people have intersected with different points in the system, whether it's corrections or emergency department, and thinking about how to target resources accordingly. Just the other thing, because I know that sort of evolving drug crisis and drug testing has been something that we've been talking about. I know that Maryland, their Center for Harm Reduction Systems, implemented a 12-month pilot program around rapid drug testing, which really allowed them to get a better pulse on the substances that are out there and better inform the community. And I think one thing that they found was how important that dialogue with those folks that are working on the ground was, in terms of providing people with information that they could respond to and decrease those risks.
In line with that, in that we are also funding a number of projects around data innovation, bringing together some of those frontline harm reduction organizations with academic researchers to get that information out, such as work at UNC with Nat Dasgupta. I'm going to switch to, we have a question about what would you recommend to increase equitable access to treatment and recovery support for those who cannot afford it, or particularly in states with higher levels of uninsured because they haven't expanded Medicaid. And Katie, maybe I'll ask you to kick that one off from the perspective you see the sort of the view across the country in terms of variation across states.
Yeah, I mean, I think states that haven't expanded Medicaid have sort of one less tool to respond to the crisis and expand services for low-income individuals in particular. There are funding streams. There are a lot of different, the SAMHSA block grants, the opioid settlement funds that can fill that gap. But I think Medicaid is really pretty critical when it comes to sustaining that access to treatment. A couple of other things I would certainly think about is in investing in federally qualified health centers, community health centers, CCBHCs, in terms of providing those safety net services. But I think it's a challenge.
Let me try to get in a couple more questions. To move along. Actually, Brad, as you were about to say something.
So, just very quickly related, I think Medicaid expansion is very, very helpful and important, but in some cases may not be sufficient. So since we have a bunch of policymakers here, let me point out just one example that we see even in states that expanded Medicaid, tremendous differences in access to buprenorphine prescribers and substance use disorder treatment within different networks. And so there's tremendous differences, even if you've expanded the insurance, if the networks and the managed care networks are too tight, how much have you really expanded? And so even simple policies looking at, is there minimal adequacy for substance use disorder treatment within managed Medicaid networks, is a potentially relatively easy lift that can ensure we have at least better access. I don't know, it'll get us to great access, but at least ensure we have better access across everyone. So I think there are these necessary but not sufficient. I do think there are these opportunities.
Sure. Thank you. And Shanazia or Doug, comments on reaction to Brad's comment in terms of our Medicaid networks?
100% agree. We have bills right now that address exactly this. You can't have, ghost providers listed, like only a certain percentage of them. You have to, right now there are bills to say you have to be able to get an appointment within 10 days. And if you can't, make that happen, then you can go out of network and have known out of network costs. Right. So there's all of these ways for network adequacy and parity that we're really working towards. So I'm hoping those bills go forward.
Yeah. Doug?
Yeah, so we received our 1115 waiver in 2018. And, it's led to an explosive growth. I mean, just, a 17% increase in residential treatment beds. I mean, that tells you kind of where we were at prior, but also the growth of the full continuum. But what we found initially was, sure, they had Medicaid, they had a payer source, but if the MCE isn't approving that treatment, then it does, they're having presumptive eligibility, we're getting them in, and then they're getting kicked out. And so we spent 3-4 years working to just right size the pre-authorization system. And so we're in the same boat. It's now, how do we begin to expand access to the rest of the continuum to ensure that there's parity across the networks?
Yeah, great, thank you. I want to finish up with a question about primary prevention. And what positions, what recommendations have you taken, or you seen effective in terms of increasing access and exposure to primary prevention efforts? And the questioner asked, noting that this really needs to be a critical component to really addressing this crisis over time. So I'll ask Dr. Cunningham first, and then Doug.
Sure. I mean, prevention is a big part of our system. We really focus a lot on schools and community coalitions. So we're in about 25% of schools across New York. We wish we were in more. We're trying to work with our school boards, because they have competing priorities. But we certainly have a robust system to provide evidence-based, prevention initiatives in these schools, really all the way from pre-K to, 12th grade. We have work in colleges as well. We have SBIRT initiatives, so screening, brief intervention, and referral to treatment, all the way through elderly individuals, so really through the whole lifespan. And then working with community coalitions, so really bringing people together in communities to address this from a variety of ways. So prevention is always part of what we're talking about, and when we think about the full continuum of services.
Right, thanks. And Doug?
Yeah, and I love primary prevention because we're preventing a whole host of societal issues, right? So to me, this is really where we get the best bang for our buck. And what I challenged our Division of Mental Health and Addiction to do when we received opioid settlement money was we're in a similar situation. We're in community coalitions, we're in our schools, but where are the other places where we know that we have we have individuals who are in recovery or individuals who are in treatment? They have families, they have children. What are we doing about those? So actually today I just signed off on feasibility study to begin to develop some pilot programs and how we can use the infrastructure that we've built to reach out to those that we know are also at high risk.
That's great. Well, we're gonna, that is a great note to end on. I want to thank all of you for a really terrific discussion. I think we could go on for another hour or so, but Dr. Cunningham, Doug Huntselinger, thank you so much for joining us today. Our partners and grantees, Katie Green and Brad Stein, thank you. My team, Ken, Sarah, Ian, and Kat, who helped put all of this together. Really terrific. And thank you to the audience. Great participation, great questions, and conversation in the chat. And we look forward to just continuing to work on these issues together with you. Have a good afternoon, everyone. Thank you so much. Bye.
Thank you.
Thank you.